Now we will proceed to our next talk, chromoblastomycosis, a neglected affliction. This will be discussed by Dr. Javeria Farooqi, who is Assistant Professor at Department of Pathology and Laboratory Medicine at Aga Khan University.
Assalamu alaikum everyone, and thank you so much for inviting all of us. I think we've discussed quite a few cases. So I'm going to talk about chromoblastomycosis. As Dr. Kausar said, it's something that we don't seem to have reported much from Pakistan, and it seems to be neglected. So I will first be just defining what it is, how it differs from other similar fungal diseases, and discuss a couple of cases, and then further, shall we say, discussion on what sort of host factors and which patients are most likely your chromoblastomycosis patients, and how to deal with them. So just to clarify, chromoblastomycosis or chromomycosis, I'm sure you are familiar with it. You see, I'm sure you see a lot of them. So the important thing to remember is that there is a broad spectrum of diseases which are similar. So chromoblastomycosis is a disease which is not invasive per se, which means that it has not invaded the subcutaneous tissue so deeply that it has become systemic. But it is a condition which is part of a broad spectrum of a disease called pheohyphomycosis. Now, pheohyphomycosis is a broad spectrum of fungal infections which are caused by a certain type of fungi which are called black yeasts. Now, they are not really yeast, it's a misnomer, they are molds, but they are called black yeasts because they look like yeast when they first grow. So important thing to remember is they can cause deep-seated or disseminated infections, right? Then they can also cause mycotomas, which is a similar sort of a condition. Then they become a little bit more superficial if you look at it, subcutaneous pheohyphomycosis. And then there's chromoblastomycosis, which is mostly limited to your dermis. And then there is a completely superficial and cutaneous pheohyphomycosis. So just letting you know where this stands. Now, there are 4 conditions which have to be met for chromoblastomycosis to be diagnosed. First of all, this is due to traumatic inoculation of the organism from the environment. So all of them are environmental fungi, mostly found in foliage, and what you require is a traumatic inoculation and causing an initial cutaneous lesion, right? Then the other thing which is required is that it is a chronic and progressive cutaneous and subcutaneous tissue response, which is associated fibrotic and granulomatous reaction. So for chromoblastomycosis, your histopathology report will definitely mention a chronic granulomatous response with microabscesses and thickening of tissue. And then what we know is that it is associated with a non-protective T helper cell response and an ineffective humoral response, which means that immunity does not seem to help much with this. And usually your patient is otherwise without any comorbids, but you do realize that the response to this particular organism is blunted, because of which this particular pathology develops. And then there is a presence, which is the most essential component, the presence of muriform sclerotic cells embedded in the affected tissue, which I will show you later. So my first case was I'm just going to discuss this. This is a 50-year-old female from Balochistan. She came in with this sort of a lesion. As you can see, it's verrucous, and it's sort of scarred as well as, and it seems to be circling her forearm. So when they performed a biopsy, the biopsy showed that there were severe chronic inflammation with histiocytic and lymphocytic infiltration, and even multinucleated giant cells, which means there was a granulomatous response. But it was inconclusive because they could not stain the fungus. So there was a lot of inflammatory response, but the fungal stains turned out to be negative. So the initial culture that was sent to us actually from that biopsy, it just grew skin flora, lots of staph and bacillus, and nothing useful. But in the differentials, we had a lot of things. We had cutaneous leishmaniasis, which could have been chromomycosis, which is what we are going to discuss. And then there was warty tuberculosis. It could have been atypical mycobacterium infection. So there was a big differential. And as you can understand, the treatment is not similar for all of these. I mean, this is a very wide spectrum. So on culture, and as I said before, it was contaminated and grew a lot of skin flora. The second attempt at culture was after we performed a lot of sterile precautions. We, cleaned it with iodine and alcohol, and then we performed the biopsy. The gram stain, it revealed dilated brown pigmented structures with transverse and vertical septations. I hope you can see it on gram stain. I know it is mostly pink, but do you see that brown structure, which is sort of it looks like a crown actually. It has dilated sort of a structure with transverse as well as vertical septations. So this is something which was very difficult to find. We just found one on the gram stain. And this is a sclerotic body. It is a toluroid and sclerotic body. So it grew black mold after 5 days, which turned out to be Cladophila caryonia. So just wanted to discuss this, that although this seems to be to have a low level of at a very low concentration of antifungals, it does get inhibited. But the question here is, was microbiology required? Did we need a culture on it when we had histo? And this is what I want to talk about, that fungal smear as opposed to histopathology is also catered to picking up fungi better, because we can sometimes use fluorescent stains, and this is what they look like. The background remains black and they fluoresce, and you can pick it up better. So calcofluor or fluorescent stain can pick up fungal structures better. Culture is again important because it will tell you which particular species it is, and the response, the expected prognosis of the disease, you will understand when we know that Cladophila responds better to treatment, and Fonseca has a bit of a problem. Fonseca species are a little more problematic in responding. So identification, and additionally, which is something that we must remember, will contribute to epidemiological data if we end up reporting it or writing about it. So publications are very, very important. Please make sure that whatever cases that you see which are uncommon, please write them, so that at least we have some literature to estimate a bit of a burden. This patient, she received itraconazole for 3 weeks, and her within 3 weeks, her lesion had decreased in size. There was granulomatous response. The varicosities had disappeared, and which was very interesting that last follow-up, the scar tissue had formed and she was doing well. So my next case was a sad case. It was a 2.5-year-old child, resident of Interior Saint, came very late with large varicose lesions, cauliflower-like lesions on his face, as well as mycetoma-like lesions in his hand. So so the deformities on hand were, as you can see, they looked very much like mycetoma, but the face was very typically chromoblastomycosis. So histopathology again revealed chronic granulomatous inflammation, and it was positive for fungal elements. This is what they